The article is blunt that skilled use of interpretation of advanced diagnostic tools is likely necessary for widespread acceptance. That is why the hands-on diagnostics position statement says it clearly. Primary care is not just a role, it is a responsibility. Here is one of the most important lines in the article, conceptually. Many clinically based tests and measures don't have enough diagnostic power to create meaningful shifts in probability. So when uncertainty persists, instrumented point-of-care diagnostics can change the game. And the authors identify two core tools physical therapists can integrate through recognized pathways: electrodiagnostic testing, EMG nerve conduction studies, ultrasound imaging, including musculoskeletal ultrasound. The article describes electrodiagnostic testing as an extension of the clinical examination that evaluates neuromuscular function in real time and supports differential diagnosis and targeted referral. It describes also point-of-care ultrasound imaging as safe, cost-effective, and dynamic, useful tool for tendons, nerves, fusions, soft tissue injury, and much more. There's a really nice visual actually on page 5 called Figure 1 there on how electrodiagnostics and ultrasound imaging plug into the clinical pathway, like history and screening, clinical exam, diagnostic testing, stronger differential diagnosis, then prognosis, plan of care, and appropriate referral and better outcomes. Now let's connect this directly to hands-on diagnostics, because our position statement and everything we've been talking about the past 13, 14 years says it in a way practice owners can operationalize it. Diagnostics are not about doing more tests. They are about making better decisions faster with the right tool at the right time. The article also makes a major point that exposure in entry-level programs rarely equals proficiency. And to truly modernize practice, we need competency-based education, hands-on skill development, progressive assessment, and postgraduate pathways. And it actually lists barriers that sound familiar to every clinic owner: lack of structured training, equipment costs, reimbursement variability, institutional support, scope ambiguity in certain regions. Here is the moment to be very direct. If physical therapy is going to claim first contact primary care leadership, we must build formal training infrastructure, not weekend confidence. That is exactly why Hands On Diagnostics filed with ABPTRFE a candidate residency program in primary care physical therapy to prepare clinicians for modern first contact practice where diagnostic tools support differential diagnosis, risk identification, and efficient care pathways. This is the bridge between the vision in the Frontiers article and what actually happens in the clinic Monday morning. Because primary care, after all, is not just a label. It is a capability